This is a respiratory system embryology tutorial presented by the SchrDbb with reference Langman Medical Embryology by TW Sadler. So here we're going to visualize the respiratory system embryology. So generally you need to know that what the respiratory system is coming from the endoderm, and the different structures also should have the respiratory system that we're going to visualize later. So endoderm is the air space of the respiratory system is coming from the endoderm. That's the first point you have to know. Then you also need to know that the respiratory system is associated with certain parenchyma, like the mesodermal parenchyma, because the respiratory system constitutes of, like the level of the trachea constitutes of cartilages and also constitutes of small muscles, and those muscles come from the splanchnic mesoderm, which is close to the foregut, basically. So now this is the element of respiratory system. So you need to know that this is generally the endodermal system inside the embryo, basically. So you start at this level, you have the foregut, then you have the midgut. So this foregut will end here, then you have the midgut, and then you have the hindgut. Now this is at the level of the foregut. You're going to have the respiratory diverticulum by 25 days of gestation. You're going to have the respiratory diverticulum which come out, basically. Here is upward. You have the pharyngeal. So here is the pharyngeal pouch, and you can see opening of the pharyngeal pouch. This is the attachment of the bucopharyngeal membrane. So down, you are going to have the respiratory diverticulum which comes out here, basically, and then this is the laryngotracheal orifice. So at the beginning, when the respiratory diverticulum starts to be formed, the larynx and the trachea is not yet differentiated, basically. So all these elements again under the endodermal system are going to be seen under this chapter. So here you need to know, so we continue now, we need to know that the trachea and the esophagus now is going to develop later. So here is going to be the lateral view, and then here is the frontal view. So as you can visualize, this is the foregut. So when the foregut is here, you see the respiratory diverticulum comes out. So you see there is already, so this is the laryngotracheal groove, but it's not completely separated. So you have a small separation between the larynx and then the trachea, basically. So it's a tracheoesophageal ridge, sorry. So there's a slight separation between the trachea and the esophagus, but they are not yet completely separated. So the trachea is now going to produce the respiratory diverticulum there down there. So this on the frontal section, you see the respiratory diverticulum starts to be divided into two. Then you have the trachea with the respiratory diverticulum divided into two with the long buds, basically. Now these are the pharyngeal arch. The pharyngeal arch seen from posterior view, basically. So the pharyngeal arch seen from posterior view, we have the arch 1 is going to produce the tongue, as you can see here. We have the foramen secum, which is the inferior part of the tongue. We have the arch 2 here, we have arch 3, arch 4, and then arch 5. So and then arch 6. So this is arch 6 here. So arch 6 is going to be involved with the larynx, basically. Since arch 6 is involved with the larynx, the laryngotracheal orifice is involved with the larynx. That's why the larynx supplied by the vagus nerve, basically, because arch 6, pharyngeal arch 6 is supplied by the vagus nerve. That's why. So that's why the larynx is supplied by the vagus nerve, because it's derivative from the pharyngeal arch 6. Now the clinical correlation. So the clinical correlation, the formation of the trachea from the esophagus is a tracheoesophageal fissura. A tracheoesophageal fissura may occur with or without esophageal atresia, depending on the types of tracheoesophageal fissura. And now we need to know that with tracheoesophageal fissura, there is a mnemonics of association with tracheoesophageal fissura, and that mnemonics is VACTER. V for, so these are the association, the sequence of association with tracheoesophageal fissura. The first is vertebral abnormality, A for anal atresia, C for cardiac defect, T for tracheoesophageal fissura, E for esophageal atresia, R for renal abnormality, and L for limb defect. So those are the different elements involved with associations of tracheoesophageal fistula bacteria. So vertebral abnormality, anal atresia, cardiac defect, tracheoesophageal fistula, esophageal atresia, renal abnormality, and then limb defects are involved in tracheoesophageal fistula. Now there are different types of tracheoesophageal fistula. The most common type of tracheoesophageal fistula is this one, where you have a proximal blind end at it, proximal esophageal atresia, and then you have a connection with the tracheoesophageal fistula downward. So this is the most common type of tracheoesophageal fistula. Now the second type of tracheoesophageal fistula is this, where you have blind-headed esophagus on both proximal and distal side, but there is no actual fistula. So this one is not actually considered as tracheoesophageal fistula. It's just considered as esophageal atresia, more preferably, because you just have a blind-headed without any connection between the two. Because you need to know that the fistula, definition of fistula is defined as it's an abnormal connection between two epithelial lining surfaces, because the trachea and the esophagus are both lined by epithelial tissues. That's why that abnormal connection occurs. Is called a fistula. Now here you can see there's a communication. Actually there are 4 types of tracheoesophageal fistula. The first and most important type is this one. You also have this type where they communicate, the esophagus is communicating at one end. So there's one communication with both esophagus here. So when the esophagus communicates at the proximal end, does not communicate at the distal end, it's a blind-ended here, esophageal atresia. So you have the blind-ended here. It is also another type, and this is a large type of esophageal atresia. Also of tracheoesophageal fistula. So A is the most common case, occurring in 90% of cases. So this is one. Then B is not actually a esophageal, tracheoesophageal fistula. C is isolated esophageal. So C is isolated esophageal atresia in 4%. So B is isolated esophageal atresia occurring in 4% of cases. Now C is the D and E other variation. So this is the other variation here. This is the H type. So now let's visualize the next. Now I've already said that the larynx was coming out from the seat pharyngeal arch. That's why it's supplied by the laryngeal nerve, basically. So this is at 6 weeks of gestation. This is at 12 weeks of gestation. Now let's visualize the trachea. So the trachea is going to divide into the 2 long buds, and the long buds now are going to produce the lungs. You need to know that this is coming from the endoderm. So we have the trachea, and then the long buds are coming from the endoderm. Now we need to know that the splanchnic mesodermal layer is also going to come and trying to enclose now this area, both from the larynx to the long buds. That's why you also have other types of parenchymal tissue on this like blood vessels, endothelial tissue, which are directly connected with the alveolar space here. Is it clear? So this is the upper lobe, the middle lobe, and the lower lobe on the right side, and then upper and the lower lobe on the left side. Now we need to know that after the when it's buried the mesoderm, now we have the formation of the different cavities, like the pleural cavity. The pleural cavity, you need to know that as the lung is going to be enclosed, you also have a pleural cavity that is going to be produced. You have a visceral pleura, which is going to be directly in contact with the lung buds, and then you have a parietal pleura outside. Now connecting you need to know that at the beginning, both the pleura and the pleura, the pericardium and the peritoneum are connected to produce the peritoneal canal, and also the pleura and the peritoneum is connected to produce a pleuroperitoneal canal. Basically, and you need to know that the lungs was initially located posteriorly, and then it's going to come anteriorly later, as you can see in the tutorial on the body cavities. Basically, so this is when the lungs was initially there to produce the different pleura. We are going to have expansion of the visceral pleura and the parietal pleura to produce the pleural cavity. Now this is the formation of the body cavity with the pleura, as we have seen already in the tutorial of pleural cavities, of the tutorial of body cavities. So in the end, we are going to have this. Now this is a maturation of the lungs. You need to know that actually there are different periods of maturation of the lungs. We have 4 main periods of maturation. The first one is the pseudoglandular period. Second one is the canicular period. canalicular period. The third one is the terminal sac period, and the fourth one is alveolar period. The pseudoglandular period occurs from 5 to 16 weeks of gestation. Canalicular period occurs from 16 to 26 weeks of gestation. Terminal sac period occurs as from 26 weeks to birth. And then alveolar sac period starts from 8 months to childhood. Alveolar sac period is when there is complete mature alveoli, and from this a child is capable of surviving without any risk of acute respiratory distress syndrome. Now, pseudoglandular period. So this is here you have first branching has continued to form the terminal bronchioles, where there is no respiratory bronchioles. So at this level, the child cannot live. Can never live on its own. So there is no respiratory bronchiole or alveoli is present. Now, in canalicular period from 16 to 26 of gestation, here in modern countries, the child can live as from this period of time, from 20 weeks of gestation, the child can live, because the terminal bronchioles now divide now to produce now respiratory bronchioles. Since there are some respiratory bronchioles, some country are capable of using a high ventilation system to make those respiratory bronchioles at their best, which in turn divide into 3 to 6 alveolar ducts. So we have respiratory bronchioles, we have 3 to 6 alveolar ducts. So respiratory bronchioles and alveolar ducts are present. So that's why some countries can maximize this and make the child to survive. Now, terminal sac period. So here this is where low income countries can now work with. So in low income country now, low income setting, you can now work here because the terminal sac and the capillary are established. So the primitive alveoli, the alveoli forms are already established. The only problem here is that there is no secretion with surfactant. Surfactant secretion starts from 28 weeks of gestation, but here all the alveoli at least have already been formed. So some low income country, though they may work here, they are not completely they may not completely work here if it has not yet attained 28 weeks of gestation, because surfactant has not yet been produced, and some countries don't use surfactant. Now the next one is alveolar period. So alveolar period is as from 8 months to childhood. So here you have mature and also have surfactant producing cells as from this level, so from 28 weeks upward. So those are the maturation. So this is how the long buds now become connected to the mesodermal region. So we have the long buds here. You see the blood capillaries from the mesodermal region are coming, and then the blood capillary from the mesodermal region gets fused now to the long buds to produce now the different alveoli with as a respiratory epithelium. So it produces the different alveoli for respiration, that's gaseous exchange. Now, what is the clinical correlation? Yes, the clinical correlation is acute respiratory distress syndrome. So, respiratory distress syndrome develops when there is a premature infant, usually less than 20 weeks of gestation, which does not produce surfactant. Why? Because surfactants is very important in make sure that the lungs does not collapse. So when a child who is less than 28 weeks of gestation, that is less than the alveolar phase, the alveolar period, he is not going to produce surfactant, though he may have respiratory bronchi and respiratory epithelium, all the respiratory part are involved. So though he may have it, he may not have surfactant, which is produced by the type 2 pneumocytes. Since you don't have surfactants, you have lung collapse. Now, when the lung collapse now is going to produce now a hyaline membrane disease, and that hyaline membrane disease is both seen in adult form of acute respiratory distress syndrome and neonatal respiratory distress syndrome. So you're going to have a hyaline membrane disease. So this is common cause of death in premature. In these cases, the partially collapsed alveoli contain fluids with high protein content. Many hyaline membranes are going to be produced, and lamellar bodies on histology section are going to be shown. Now, another clinical correlation is going to be ectopic lung lobe. So ectopic lung lobe is arising from the trachea or the esophagus. It is believed that this lobe are formed from additional respiratory buds. So when you have an additional respiratory bud, you can have an ectopic lung lobe. The next one is a congenital cyst of the lung. So congenital cyst of the lung is formed because of dilation of the terminal or larger bronchi. So we have congenital cyst of the lung. This cyst may be small and multiple of the ventricle. So that's it. So from here we are finished with respiratory system embryology. So I say thanks for your kind attention. Don't forget to like and subscribe to our channel. Thank